Good afternoon, everyone. This is Jessica Porras, Senior Manager for Education and Policy at CAQH Core. Thank you for being with us here today. We're very excited to share this information with all of you. Next slide, please. Here's the agenda for today's webinar. First, we'll have a speaker from CAQH Core, give a little background on level set. We'll have our next presentation focused on the CAQH Core Pilot and Measurement Initiative. Then we're happy to have a speaker from Cleveland Clinic go through the case study that will describe their experience with automating the PA workflow. After that, we'll have a panel discussion where we'll get a little bit into more detail on some of the learnings from this study, and then we'll have some time at the end for Q&A. Next slide. I'd like to share a couple logistical items with you. If you see there on the right-hand side of the dashboard, you can access the presentation if you click on that presentation on the handouts feature in the dashboard. In addition, we'll send you the slides and the recording after this webinar. And the last thing is, if you do have questions, please feel free to ask them at any time, and we'll try to get through all of them at the end of the webinar during the Q&A. Next slide. I'd like to thank all of our speakers for being here with us today, in particular, Dan Medve, who's the Director of Pre-Access at Cleveland Clinic. Dan joined Cleveland Clinic shortly after graduating from University of Dayton in 2007 and has been at Cleveland Clinic for over 12 years in several progressive roles. Dan is passionate about continuous improvement, engagement, and supporting professional development within Cleveland Clinic. In addition, I'd like to welcome Daniel Dedels from PriorAuthNow. He's an SVP of Customer Operations with PriorAuthNow. He and his team are charged with the integration, customer support, account management, and partner enablement across PriorAuthNow's broad portfolio of health systems, strategic payer relationships, and distribution partnerships. Thank you so much for being here with us today. Next slide. And now I'd like to welcome Robert Bowman, CAQH Core Director, who will continue with the next presentation. Bob?
Great, thank you, Jessica. And as Jessica mentioned, we do want to give you just a little bit of a background on who CAQH is and why we're in this space. So on the next slide, you'll see that CAQH Core is a mission and vision-driven organization made up of many participants, over 130 participants from all sectors of the industry, and all stakeholder groups as well. We actually represent over 75% of the insured lives in the United States. So we really look at that broad base and coalition, as well as consensus building and building what we call operating rules. We have been designated by HHS as the National Operating Rule Author, and we hope to drive industry to build more efficient, more accurate, and more effective interactions between providers and health plans. Again, as that role, we do develop operating rules. We work with our constituents in making things a lot better. Part of this is actually driven by our core board, and our core board is a multi-stakeholder group as well. And that board is made up of health plans and providers working together to identify challenges and then how we can work together as an industry to mitigate those challenges and make them much smoother for the industry. On the next slide, you'll see that we've been working for 15 years now in the industry and doing just that, in developing sets of operating rules for each of the major interactions that a provider has with a health plan, from eligibility and benefits to claim status to payment, remittance to prior authorization, on through claims and the rest of the HIPAA transactions. We've been building the operating rules again for 15 years, really building off of not only a firm foundation of connectivity and infrastructure rules, but also looking at data content. Right, providers and health plans both need very specific bits of data from as they really interact between each other to ensure that they're really having the best business function that can take place. So we look at standards that exist in the environment in our industry. We look at standards in other industries, and we develop these operating rules to make sure that really a provider can have the best interaction with a health plan as fully as automated as possible. There's lots of potential savings and cost reductions by moving to a more automated process, right? As we're all using technology to make things better, we want to look and see how the best way we can do that. Part of that is looking at and identifying very specific barriers. And on the next slide, you'll see that we do have a whole host of potential barriers for the electronic adoption of prior authorization. A lot of this relates to many things that we see for any other industry where there's lack of adoption, lack of consistent data. Again, data content rules come into play to help resolve this particular issue. But because the very specific data needed for a prior authorization, like member information, diagnosis code, dates, provider information, is just like the information that's needed for a claim, we can really piggyback on the development process that we saw for claims as claims became more automated back in the 80s and 90s and became more electronic. And we dropped the paper submission of claims all the way down to 1 or 2, 3% now, right? Almost all claims are billed electronically today. We're looking at that same kind of pathway for prior authorizations, right? Part of the problem also, though, is that there's lack of integration, there's limited availability, there's a lot of levels of maturity within the system. Some plans are much further ahead than other plans. Some providers are further behind than other providers. Vendors are recognizing this space as a place that there really can be a lot of lucrative business because providers really need a solution. Health plans really need a solution. So looking together and working together with our vendors and clearinghouse partners, the industry can actually make improvements on many of these barriers. If we move to the next slide, you'll see that we have been working on prior authorization for a couple of years now. And what we've done is actually put together a set of rules that we're proposing to NCVHS for federal mandate. This includes our infrastructure rule, our data content rule, and our connectivity rule. The infrastructure rules have very specific requirements related to how you actually move things around, right? It allows for response times, right? If the provider submits a transaction into the health plan, they need to know when, then you know it's been received, it's been accepted. They need to know what the system availability is. Companion guides really help vendors communicate with each other and with providers and health plans. That infrastructure rule also sets a 2-day response time for health plans requesting supporting information or additional documentation from providers, as well as sending a final determination. It also, with the data content rule, as I mentioned, it targets one of the most significant problems in the PA space, and that is particularly related to pens. When a PA is pended for additional information, providers need to know that as quickly as possible, can remit that information so the health plan, can move forward with that, making that review and making that determination. Last but not least, connectivity rule allows for health plans, providers, and vendors and clearinghouses all to really look at a single standard for connectivity, security for the data as it moves from point A to point B, and ensuring that the system, the network, can be built so that everyone can interoperate with everyone else. So as we'll see later today, Cleveland Clinic interacts with many, many health plans. The best way to do that is using a single standard and a safe harbor type connectivity so that everyone can interoperate together. With that, I'll hand the call over to Rachel to begin our conversation around the Pilot and Measurement Initiative. Rachel?
Great, thanks, Bob. So I will provide a quick overview of that initiative for those of you that may not be familiar. And this will really set the stage for getting into the case study portion, which is, I know, what you've all been waiting for. So next slide, please. CAQH Core and CAQH Exploration started planning for this initiative, the Prioritization Pilot and Measurement Initiative, last year and launched fully in Q4 of 2019. Many organizations want to know if the work that they're doing is worth the effort in terms of process improvements, particularly in the prior authorization area, as that's a big one with potential for efficiency. And they want metrics to back it up. They're craving success stories and lessons learned from counterpart organizations. And CAQH Core and Explorations know that standards and operating rules really do save time. And our CAQH index work shows this, and our years of environmental scanning support that as well. But this initiative really serves to measure a layer down. to use the insights that we get from those measurements as both a continuous improvement feedback loop for core operating rules, as well as a way to offer guidance for implementing organizations in industry who are looking for standard ways to measure their PA improvement projects and improve their workflows. So that's really the soul of this measurement initiative, and bringing uniformity and consistency to the way we measure the impact of prior auth automation and enhancements, so that organizations can really track and articulate the impact. Next slide, please. This slide shows our typical engagement model. Every grouping of organizations that participates in this initiative works slightly differently, of course, based on their timelines and the composition of the organizations that are trading prior authorization information with each other. But this is a typical kind of 5-step engagement model for us. One of the major benefits we've heard from our participants is that when you work with CQH Core and Explorations on this initiative, you do receive the guidance of a neutral third-party nonprofit organization with expertise in prior authorization standards and operating rules. And so we really work to identify organizations that are trading partners with prior authorization, so at least 2 organizations, to have a pilot grouping. For example, it could be a health plan and a health system, or a health system and a prior authorization vendor that works with health plans. And we capture the current state and desired future state via review of technical specs, interviews, shadowing. We help to design the measurement approach, identify appropriate comparison groups, and priority measures. We'll talk about measures in a minute. And we also can support the data analysis and articulation of findings, offer recommendations on how to further streamline, and really provide opportunities for these organizations to report out and share successes with the national audience, much like we're doing today with Cleveland Clinic and PriorAuthNow. On the next slide is a list of standard measures, and this list of measures, an organization isn't required to collect all of these measures to participate in the pilot and measurement initiative, but we've worked with several implementer organizations to build these list of measures. And the goal here is for each pilot grouping to track some of these, so we have a common list across, which allows for more impactful aggregate takeaways. So I'll leave this here. You guys have these slides, and you can feel free to take a more detailed look after the call. But I should note that they're organized into 3 major categories: volume, time, and ease and satisfaction. And you'll see this represented as we walk through some of our slides today. So a combination of these measures can inform calculations for overall impact, such as potential savings. Next slide, please. So while we have quite a few organizations in our initiative pipeline, the challenges with the COVID-19 emergency have understandably interrupted some of the measurement activity. I'm sure many of you are dealing with that as well. So that being said, we're glad to report out on initial findings from ongoing work with Cleveland Clinic and PriorAuthNow, which is one of the groupings within our overarching initiative. So I'll provide just a very, very brief introduction and then turn it over to Dan Medve from Cleveland Clinic, who will get into the details. So in mid-February of this year, 2020, Cleveland Clinic began rolling out PriorAuthNow, which is an automated solution that leverages APIs, the X12278 standard transaction, as well as operating rules, and connects directly with health plans. And they rolled this out for a subset of prior authorizations for specific plans, starting with one national plan, with subsequent go-live soon after. Today is a total of 34 plans, various sizes, lines of business, mix of payer types. And this is for diagnostics, so imaging and cardiology diagnostic imaging prior authorizations. We've done quite a bit of work together, and the broader study looking at the impact of these workflow enhancements was 3 parts. You'll see that on the right-hand side of this slide. And today we'll focus on some initial findings from a survey of Cleveland Clinic working with the PriorAuthNow solution, as well as some select measures that are available to share now. And in the future, we're looking forward to sharing results of a comparative analysis that will provide more robust quantitative impact information once resourcing and volumes, those changes from COVID are more normalized. So I'm going to go ahead and pass it over to Dan Medve, Director of Revenue Cycle at Cleveland Clinic, to discuss Cleveland Clinic's experience with all of this. Dan?
Thanks, Rachel. So good afternoon, everyone. My name is Dan Medve, and I know it's been introduced, but I support our authorization team here at Cleveland Clinic. And so as we go through the next slide, and a couple of slides here, we'll kind of dive into a little bit more in terms of what we're looking at, what we experienced, so what story is there to tell in terms of what we went through, what we saw, some hurdles or some outcomes that we were able to identify, and just really talk through this as a solution. You know, for those maybe not familiar with Cleveland Clinic, the next slide kind of gives just a high-level overview of what we are, but we do support, we are an international organization with 60,000 plus employees and caregivers across the world here. I really am here to help support the Ohio authorizations. I work closely with our Florida partners as well as in Nevada. And really, this is just kind of a high-level overview of who we are. But what I really want to do is kind of talk about the prior authorization process and kind of where this was. So as we move over to the next slide, you know, we're going to talk a little bit about the reality of prior authorization. It is a burdensome process. There's a lot of waste. So when you look at a process itself and look at what is wasteful or what adds value, the process of initiating prior authorization requests, so checking if authorization is required, going in and creating a case within the payer portal, that is waste. It's needed because we need to be able to make sure that the right information is being delivered to the payer. But in the aspect of having a human do it, a human mind to take that concept and put it over, that's where waste is. The value is the clinical information needed to support that test or support that service that's in question. And so, you know, there's a lot of waste and duplication of efforts. You know, we may submit an authorization and then have to follow up 2 days later, and then 4 days later, then the weekend hits, and you know, Monday we have a decision, but we actually could have found out Friday because that decision was made about a half hour after we last contacted the payer. Standardization is huge. So as you heard Bob and Rachel both speak about it, having a standardized process is critical to ensuring a smooth workflow, but it will benefit the patient in the long run because they're able to get quicker access to care. They're able to get more direct access to care. And then, you know, what we're going to talk about here with prior authorization and Cleveland Clinic and prior authorization now, it's one solution. And there's not a single solution. And I think that's the important message I really want to make sure everyone understands is, you know, there are transformative solutions that are out there, and it's trying to identify and find the ones that work well together. So that's what we'll kind of go through here as we move over to the next slide here that kind of talks about how I'm approaching the prior auth solution and AI and where there's opportunities to leverage automation. One, it has to make sense. I don't want to rewrite my entire operation because with 60,000 plus caregivers that are familiar with it or somewhat familiar with it, that would cause a lot of bottlenecks, a lot of confusion. And the prior authorization space is very convoluted to begin with, and having to change a lot of that is really critical to be able to do. And it's one of the key driving factors as we go through to decide in how we're assessing this and prioritizing our work. You know, value-based is really important. The prior auth process can vary amongst payers, services, you know, whether they're in state, out of state. There's a lot of complexities there, and having a solution that understands that and is able to support that is critical because that's really going to make a smooth process and really drive a more frictionless process as you move forward. And as I mentioned previously, I mean, there isn't a single solution. So I'm looking for a solution that has the ability to interoperate with other solutions that are out there. You know, with this process here that we'll go through, it's really leveraged and driven by the 278 notification. So that form of a transaction. The 275 isn't part of this, but that is an opportunity. So how can a solution that helps drive the 275 utilization operate within this automation opportunity here? And then the last is the payers. So, payers are key partners on this. Without having that payer partnership and that payer willingness to connect and willingness to improve that process, you can't really go too far. And so being able to work with the patient and understanding what the payer can do is really critical. And there's only so much you can do without the payer's involvement. And so as we move to the next slide, I'm really just going to take a high-level overview of what that auth automation process looks like with PriorAuthNow. There's a lot of decision points as we went through the build on this, of identifying and mapping up, payers and our payers that Anthem supports. There are some challenges there that we have to come across just due to varying level complexity that each system or health system may have in terms of how they categorize their payers. But at a high level, the PriorAuthNow solution is able to identify which payer you have that is registered in your Epic account, and identify this payer needs to go to this portal for processing. And so that decision there, again, is an opportunity to eliminate waste. It eliminates, the ability or the potential of an error or choosing the wrong can add time and frustration. The auto-population all the patient information, the demographics, subscriber ID, the CPT, the diagnosis, the tax ID, the NPI, all that is fixed depending on how your system is built, or in our case, we have it all housed within the referral. That information is auto-pulled when this case is auto-created. And so PAN will take a completed request, which we have some varying operating logic in place, so it has to be coded with a diagnosis and CPT. The data service is within 30 days. If it's more than that, we actually hold it and we have to manually trigger it out, which is not a difficult process, but it avoids something that goes out 6 months out down the road. And that's something we learned when we first turned this on. We had a cancer imaging, and the data service was 6 months out. And so we were able to identify that pretty quickly and put the stops through. Once that payer makes that decision or that the case is received, there's some action we need to take. So, managing a defect. So we either have to answer the clinical survey or upload clinical, or it's a payer that Anthem or that PriorAuthNow doesn't support because it's an Anthem plan, but they don't utilize, one payer or whatnot. There's the ability for us to then interact right away because we get that status. And the statusing update it does come back right away to us, which is great to see because that eliminates the wait time. And if you put yourself in a patient's shoes, having to wait on this is pretty frustrating, challenging, because you're what's wrong with you or what's wrong with a family member. So being able to focus on, sitting there and having that quickest access to care, because those decisions are automated, that can save off hours to days throughout the process. The ability to know additional information is needed to do, and then driving it to that payer portal or driving us to those clinical surveys is, again, it's an opportunity to save time, eliminate error, and then we have the ability to add some free text for additional context to support the prior authorization. And so that's really important. So when we look at this whole cyclical process, we're still involved at a very high level. We're still operating within the Epic EMR. We're still involved in the case. We're touching essentially 100% of the work still. But what we do is when there is a defect, and that's the value that we're really focusing on here, to focus on that clinical survey. So not necessarily having to spend 10 minutes of a 15-minute process or 15 minutes of a 20-minute process on case, putting in all the information, moving tax ID from Epic into the payer portal, to really focusing on, are we submitting the right information? Are we answering the clinical surveys to our best ability? That is where that value is in that process. And we move on to the next slide here. This really just kind of takes what I just talked about, the various items in terms of what we are doing and how we're interacting with the case. So that top line really is looking at all the work that we do outside of HANS integration. So all the work within Epic, initiating the case, submitting the clinical, those are all manual processes that we are going through and that we're completing and spending time on. And through various, we know that can take anywhere from 15 60 plus, depending on the how long that lead time is for that decision to be made. The bottom section really looks at what value is taken from this integrated solution. So all that work, initial working within Epic, identifying the case, gathering all that information, selecting the correct payer portal, the initiation, all that is automated. And then we interact when there's a need to manage that defect. So the clinical submission is our manual interaction. And then the ability for, as soon as a payer makes that decision, and that case is, there's a decision, that follow-up is written back, again, from PAN through the 278 into Epic. And so all of our core requirements that we need to move a case forward, the authorization number, the date range, the CPTs that are approved, all that information is driven back into Epic. And so the next slide will kind of give a little bit more detail in terms of what's there around the automation. Again, really the focus there is what actually needs to be done by a human being. That's huge. And that opportunity to not have to be involved in so much waste in the process is really helpful to, driving a solution. So that clinical submission piece on the bottom, that's really where it's an opportunity for us to enhance our caregiver. So we have gone through some extensive retraining on identifying clinicals, managing defects. So if we see a case come out that, we know that this payer requires, 3 to 6 conservative treatments, and we don't see that, and we see, that there's a limited amount of information there, it gives us the opportunity to say, how do we want to manage this defect? We could submit the case, let it go through the denial process, the peer-to-peer, notify our providers, or is there an opportunity for us to come back and educate our provider, educate that, hey, here's what's needed, and really drive the improvement there. So it's an ability for us to even manage our defects internally better. So the next slide is really going to take you through just a high-level overview of what the solution does look like. And this is a real example. So we had an MRI that was scheduled on February 10th. It was scheduled at 9:42 a.m. for a date of service of February 21st. So it gave us 11 days to obtain authorization from when they scheduled that patient. We know payers are allowed 14 days to make that determination in terms of if it's approved or denied. As soon as that case was scheduled, it went out the door through the integrated solution. And so when we look at this from a timestamp, it was the exact same time that it qualified. So it was a complete referral, coded, diagnosis, all that information was there, and it was scheduled within 30 days. We had a notification go out to the payer, and then we had a real-time response written back indicating that there was a need for the clinical survey. So again, our involvement managing that defect. So we actually got into that case 11 minutes after it qualified for our work queue. We clicked on the link within PAN, and that drives us directly to the payer survey. It took 4 minutes to go through, complete the survey. And then as soon as we submitted the survey, the payer's system indicated the approval, and PAN had written that back into Epic. So when you look at this, our interaction from a timing standpoint was 4 minutes overall. The time it took us to click the link at 9:53 a.m. and submit the clinical survey at 9:57 a.m. For a patient, it was 13 minutes, and they had a notification that your service is approved. We have an authorization. Not that it was no pre-cert required, we actually had an authorization for this case. And the beauty of what this opportunity presents is that impact to patient. And so, as I mentioned, solutions that can work with this and support it. Patient transparency is really important, especially as patients are not as knowledgeable on their benefit plans because they are quite confusing. It's an opportunity to sit there and provide that patient relief, knowing that, hey, I just had this appointment, I have a scan now I have to have done in 11 days, and then the ability to leverage, say, Epic and their MyChart notifications. We could then inform that patient, hey, your scan that you have scheduled on February 21st. And so that's really what this overview here provides. So as we move to the next slide and walking away from what that overview was, we really looked at it measuring in twofold, so qualitatively and quantitatively. So qualitative, we saw stress reduce in our team. They don't have to be so concerned about making a mistake throughout that whole process, or I have to go here, do here. It's a lot of repetitive. Whereas if you're just managing the clinical defect piece, that's something that's new. It's challenging. It's not the same over and over. They're more rewarding because they're involved in what matters. They're involved in that value base of that patient care. The system is really easy to learn in terms of how to manage it and how to drive through it. And it gives us an ability to manage that team, not just a case by an individual. So if someone goes out, you don't have to have that person kind of wait to return or have someone else start a case. Someone else can just pick that up and start working through it again. And so it really allows us to be as efficient as possible in terms of managing our work, managing the turnaround. So what we had built in Epic is, as a defect come back where additional clinical information is needed, we have a separate work queue that captures all of our 278 information. We're able to go through that, and then it's on us to make sure that we're responding and taking ownership in those requests as quickly as possible. And then from the quantitative spectrum here, it's really focusing on the efficiency, how quickly things are getting done. Patient access is critical, and that's my focus here as we go through these automation solutions is, how is it going to benefit the patient, or what is the benefit for the patient? And then, as always with the process, I want to focus on that value. I want to remove the waste, and I want to create a more streamlined process. And that's where that partnership with the payers is critical as we go through down this road. So the next slide just kind of goes through in terms of the indications out there around the performance, but some of this volume was impacted by COVID. So as many have experienced a major decrease in volume, we saw that when, for the majority of our measurement here. We also kind of scaled our implementation. So we started with one payer and one group of services, and then we advanced and expanded where those opportunities were. But overall, we were seeing about a third of the cases result in the same day approval. Additional measurement efforts that we have here are to, how do we know more about that tail? So when that case was ordered until they had approval for access to care, because that's really a driving indicator in terms of time to treat. And so we're committed to that and partnering with CAQH and PriorAuthNow to drive that forward. The efficiency, it's pretty in terms of, all right, here's how much work is able to be done now. When you look at the time and the efficiencies gained, where there is opportunity just to focus on managing that defect. And then ultimately, understanding what those operations are and how do they impact that case history. So again, that story, that tale of from when the case was requested to the ending outcome, we know that there can be a few different outcomes. And so how do we leverage the data that we have and tell that story, not just from a percentage standpoint. I really think that's critical there. So I know I kind of just went on and rambled here. So I thank you for allowing us to take the time to talk through this and kind of what we experienced at Cleveland Clinic. Plan to move forward and throughout the rest of this discussion, we'll have here. So thank you.
Great, thanks, Dan. I am going to go ahead now and share the initial findings from the provider staff satisfaction survey at Cleveland Clinic. And this was administered by CQH Core and CQH Explorations to the Cleveland Clinic staff caregivers working on this solution. And I know that Dan touched on, some of the initial indicators of these workflow improvements, and I think these survey findings will offer some additional color. And again, they're directly from the caregivers who are actually conducting these authorizations. And Dan did a great job, I think, speaking to that. So, Dan mentioned that the PriorAuthNow solution and walked us through this, leverages the standard PriorAuth transaction, leverages the core operating rules, fits fits really neatly within the provider staff workflow, and also leverages the API technology and direct connections with payers, which is really essential to streamlining the success, streamlining the process and seeing some successes here. I should note that the core operating rules related to patient identification, response times, communication of clinical info needed, and status updates are all really within the spirit of this automated workflow and within the process that Dan just went over and seen in this process change for the staff. So the survey, with all of that in mind, sought to gather information around how this impacts the Cleveland Clinic staff experience and their satisfaction. And like I mentioned before, a separate but related impact analysis later will share some additional quantitative results in the coming months. So this is just a preview for you all. So this survey was administered in July, last month, and was responded to by a team of the caregivers at Cleveland Clinic who are assigned to the prior auth that come through the PriorAuthNow solution, which represents a large portion of diagnostic volume. And staff were asked their opinion on a list of statements. So they were given an option to, of course, indicate a neutral position. And I should note that in some cases, higher neutral responses correspond with workflow steps that may not apply to the entire staff respondent pool. So I'll go ahead and share these initial findings. We've grouped them into 4 major themes you can see on the bottom of this slide here. So the first one is less time spent completing prior auth tasks. The second is reduction in the wait times between steps in the prior authorization process. The third is increase in real-time interactions and automated interactions. And the fourth is we saw an increase in staff satisfaction. And all of these align with what Dan has just gone over as well. So I'll dive into all 4 of these themes in the next few slides. So the first one here, if we can go perfect, relates to time spent completing prior authorization tasks. And as Dan noted, one of the most significant burdens from a provider staff perspective related to prior authorization is time spent and often very manual time that's very manual in nature to work on a prior authorization from start to finish. So what we saw from the respondents here in this survey was that overall the amount of time that the staff spent completing a prior auth was less when using the automated solution than when compared to conducting a prior auth through a direct payer portal. So you'll see here that over 2/3 of staff reported that they saved time actually initiating the prior authorization request. And Dan went over kind of what is within that stage of the workflow on some of his prior slides. We also saw that over 3/4 of the staff surveyed indicated that they spend the same or less time checking on the status of each prior authorization request. And so really we're seeing these time savings in areas that historically organization after organization that has researched the burdens of prior authorization, including CAQH Core, have really seen these as very manual in nature, time sucking parts of the process. And so we're seeing this reduction in time here. And one of the respondents said, you know, this is really a significant change in the initiation process itself. You know, we enjoy it, I enjoy this process, more time to actually review the clinicals and correctly answer the clinical survey. And that's when, you know, that additional clinical information is needed to move that auth request forward. And Dan spoke about that, and that aligns with what he's seeing from his staff as well. On the next slide, I'll go over our second major theme here out of 4. And this has to do with reduction in time. This has to do with reduction in prior authorizations that have wait times for next steps. So what does that mean? I mean, Dan spoke a lot about how when you move the prior authorization throughout the process, you can often just be kind of sitting there waiting to hear what's needed next, what to do next to move it forward. And what the survey found is that, the automated solution communicates these requirements for next steps and reduces the turnaround time and manual steps in the process. So most staff reported seeing fewer prior authorizations that have wait times to communicate the additional clinical information that's needed. So this is, think back to the slide that Dan had discussing how in real time they're seeing what clinical information is needed. The second big finding here is that 2/3 of the staff indicated that the amount of time between clinical survey and final determination is generally shorter. Finally, 2/3 of the staff reported that overall turnaround time for a prior authorization request is shorter. So here we're seeing time savings again, but from a little bit of a different angle, right? So time savings, but also time savings between the next steps. And I think that's a really huge deal. So someone reported, I find I'm able to submit more cases in a shorter amount of time as opposed to starting from the beginning on the portal itself. On the next slide, this is our third theme here. Automation and real-time interactions are seen to be especially valuable. And, Dan mentioned that one of the main drivers of all of this really is, obviously wanting to reduce staff stress, increase their satisfaction, reduce burden, but also wanting to have timelier delivery of patient care. So having real-time interactions is especially valuable when it comes to both of those things that I just mentioned. So nearly all staff indicated that a single workflow is valuable, and that auto population of patient, procedure, provider information into the prior authorization request is valuable. Over 3/4 of staff indicated that automatic real-time status updates are valuable, and reported that knowing in real time what clinical information is needed is incredibly valuable to move the prior auth through the process. On the next slide, we're reporting out the theme around staff satisfaction. And Dan spoke about how, he's really seen decreased stress in his staff. And I think that's huge. We're hearing a lot about provider staff burnout and how that's potentially, very problematic, right? For obvious reasons. And here, staff are reporting that using the automated system is easy and it reduces job-related stress. Most reported that. Also reported that understanding next steps to move a prior authorization request forward is easier. And that they were able to focus on the more critical elements of the prior authorization process. There were themes around increase in productivity and feeling more comfortable in their position as a staff member. And I think for staff engagement and morale, that's a really nice finding there. So really, this solution, which leverages the standard, the operating rules, the API technology, it saves time and adds meaningful value to the aspects of the workflow that the staff are responsible for. This is what we're seeing just in this first survey. And of course, most importantly, the hope is that all of these time savings and efficiencies ultimately enable timelier delivery of patient care. And I think we'll get into more discussion around these initial findings and what's next for the impact study in the panel discussion in a couple of minutes. But first, I'll send it to Jessica for a quick polling question for all of you.
Thank you, Rachel, and thank you, Dan Medve, for your presentations. Let's go ahead and open up this poll question. It's a check all that apply, and if we'd like to hear from you, which of these prior authorization operating rule requirements are most impactful or would be most impactful for your organization? The first two options have to do with maximum response time, the second two with data content, and finally, the last option is regarding connectivity. I'm just going to keep this open for a few seconds, and then I think what we'll do is we won't share the response because I really would like to move forward with our panel conversation since I'm excited to hear what they all have to say. So let's go ahead and close the poll and go on to the next slide. If you could go to the next slide. So I introduced some of these speakers earlier for the panel presentation. We're also joined by Dedels, who I introduced earlier, as well as Kristine Burnaska, who's a Director of Research and Measurement at CAQH. And Bob, I know you're moderating, so please take it away.
Great. Thank you, Jessica. And we do want to just dive right in. I know we want to make sure we ask as many questions as we possibly can. So for both Dane and Dan, we start off with, how did the implementation of the PA automated solution impact the administrative burden and patient care? I know, Dan, you mentioned some of that initially for Cleveland Clinic. Would you like to elaborate?
And as I hit on it, the speed and of how those operating rules PriorAuthNow is leveraging, the ability to get those responses back time is huge. It reduces the manual processing of checking status, whether calling or looking on a payer portal. And all that does is, in turn, it provides a quicker pathway to care. And so if we know that we need to answer a clinical survey minutes after, or real time after we submit a case, we can take that action. And then it's up to us to own it from an operational standpoint of how quickly we're able to work this work. And by doing that, we're getting decisions quicker. We're having, more success of providing care, even if a peer-to-peer is needed, because, a peer-to-peer, this PriorAuthNow solution that's out here, it doesn't necessarily improve access because it's still based on the validity of the order and whether it's following the appropriate pathway. But if we know a peer-to-peer is needed, essentially a minute after, we can take that action. The ability for that to have a longer time to complete the peer-to-peer is huge, but also for to manage that, so that is as closer to service, which creates some additional barriers there for access.
Yeah, Bob, if I could just add on there for a second. This is Dan from PriorAuthNow, and really the critical component of our implementation is embedding our product and value directly into the workflow that the caregivers are leveraging today. This, in combination with capturing the critical data elements needed to submit the authorization and our direct payer integrations, it eliminates the follow-up, it eliminates the manual data entry, and this model has worked really well with Cleveland Clinic, our other partners, and is really a framework and a philosophy that we will continue with as we deploy additional value-driving solutions into the market, both for our providers and our payer partners.
Great, thank you. Maybe now a little into the detail a little bit, if we can. How did the specific operating rules or the 278 standard help integrate this with the provider workflow, for example?
This is Dan Medve. It streamlined it. It gave us a clearer view in terms of how to operate and navigate the prior auth process. The operating rules there, in terms of the timing, set forth a consistent expectation in terms of how often we're handling, when we're getting involved, so that we could manage our operations to support that. And so by integrating it within our operations and our process flows, we didn't have to change that. We had a strong process that we're able to then continue to leverage, where the solution's able to automate or expedite that decision based on those operating rules.
Great. Rachel, do you have a perspective as well, having worked in developing the latest round of batches of operating rules that we have?
Sure. So I think what's really nice about how the operating rules integrate here into this case study is that a lot of it is really happening in the background. The provider staff are just kind of feeling the impacts of it, but not even really, totally aware of, oh, this is happening because of a core operating rule, or automation because, there's a real time, specifically the status codes here are being used, et cetera. And so I think that's really nice. And I think we definitely, like Dan said, see the real-time responses and the some of the data content requirements.
For sure. So Dan, actually, let me back up and follow up maybe. Are there additional needs for standardization or operating rules from your perspective? Where's the gaps? What else do we need to do as an industry?
Yeah, so I think, as I mentioned earlier, this is one solution. There's many that are out there that can continue to improve that process in terms of how information is shared. The operating rules around the 275. There's further expansion available there. On the 278 side, it's really how do we navigate the benefit aspect of it too. So not just that authorization is needed, but knowing and helping align that patient responsibility, their benefit coverage is really important. And how does it all merge together? I think that's really what I'm focused on. But the real-time updates, the acknowledgement of those returns of status, those are really strong and really impactful to driving an enhanced solution, an enhanced process.
I think that's a great leverage maybe here for Dan Dedels as well. How does the PA solution developed by PAN work within the provider staff workflow? How does that help?
Yeah, I mean, honestly, it was very clear to us from the start that the caregiver wanted a single streamlined experience within the work queue and the workflows that they were already utilizing today. Our ability to support that experience through the integration of multiple payers, allowing for auto determinations, eliminating a lot of the manual follow-up activities that Dan Medve alluded to earlier, is really what's led to our rapid adoption rates within the market, and is quite honestly why we are placing such significant resources on our side for continued payer and service line expansion, supporting more service lines through the PriorAuthNow solution.
Great, thank you. And maybe Kristine, for you, what are the next steps post-COVID-19 with the measurement efforts that we have with Cleveland Clinic and PriorAuthNow? I know, as we mentioned before, the pandemic had impacted part of the implementation and part of the process, but now that we can move forward with some additional studies, perhaps?
Yeah, no, that's a great question. We are, as Dan had mentioned, working with Cleveland Clinic and to obtain some comparison groups. What we think would be useful is to start looking at kind of pre and post implementation to show what actually occurred prior to this automated solution, integrated solution, and then what occurred afterwards. We've already seen qualitatively, and also Dan has seen some quantitatively, that there have been reductions in time as well as some staff satisfaction measures that have increased. So we will continue to work with them. We're also continuing to work with other partners. And as Rachel has indicated, working through that 5-step model where we start at the beginning with identifying some matches and then moving forward, identifying metrics, et cetera.
Great, thank you. So more to come. That's great. I know we're getting close on. I know we're getting close on time, so I'm going to kind of just jump into some of the questions that we received online, both again during the registration process and also during the conversation this afternoon. So, and again, I'm just going to ask the panel if they have any comments or questions. The first one may be directed to Dan from Cleveland Clinic. You mentioned the word defect. That's a term that you use specifically for one of the prior authorization examples, right? What can you maybe explain what that terminology means by defect? Does it mean that it has been kind of pended? The prior authorization has been pended and the pend has to be removed before it gets moved to the next step for a potential authorization?
Yeah, absolutely. So when I use the term defect, my mindset is from that continuous improvement process. And so a defect is where we have to take action either, multiple times, or there's additional rework that's needed. So with the prior authorization process, the defect in what can be automated is that we have to stop the process, we have to go upload, we have to go complete the clinical survey. That's our involvement in what the solution brings forward.
Great. Right, so the automation component between that real-time response back allows you to see what the reason for the pend was, and you can work that pend, adding additional clinical information or data, specific data, right? So that helps to kind of smooth that process, that iteration back and forth, the dialogue that we hear that takes place so much, that burdensome component. Having that pend reason back immediately, right, within real time, allows you to work those much more expeditiously and more cleanly, right? So it really helps smooth that process and that abrasion. I know we've got a couple more questions here. Maybe we have a couple more minutes. The example was a relatively low complex prior authorization. It's kind of around the question around how complex do the prior authorizations get, right? Do you do surgeries through using this process, or what are the kind of categories of service that are implemented so far using the PAN solution? And that's for both Dans. Either Cleveland Clinic might have something specific, and Dan may have other clients using different models.
So this is Dan. The services that we are leveraging this tool for are through a few dedicated payers. And so it's really MRI, CTs, echoes, some cardiology testing that way. Dan, I'll let you talk about your approach in terms of, growth there or opportunities to expand.
Yeah, as Dan mentioned, we started in the diagnostic space, and as I called out a little bit earlier, we are placing significant resources on our side in conversations with direct payers for the sole purposes of expanding our payer footprint, as well expanding the service lines that we are offering through PriorAuthNow, including surgeries and other modalities from there.
Great. Thank you so much. I want to thank all of the participants for our panel and for everyone for attending this afternoon. I'll hand the call over to Jessica for one more polling question before you head out. And again, we thank you for your time this afternoon.
Thanks so much, everyone. Really appreciate the conversation we just had. So yeah, let's take one more second and see if any of you are interested in joining the pilot and measurement initiative that Rachel talked about earlier. We do have several partners we're working with, but we would like this to be a long-term initiative, so look forward to working with some of you. So let's give this a few more seconds, and then we will, follow up later. We don't need to share these responses. So if we could go to the next slide. So if you're interested in joining CAQH Core in order to draft operating rules, here are some of the benefits in addition to helping to draft the operating rules. Next slide. And if you have any questions or comments, feel free to email us. If we didn't get to your questions, and I know there were quite a few more, please send them to that email address and we will get back to you. Thank you, everyone. Have a great afternoon.